Well, welcome everyone to a special Spotlight Montana, focusing, of course, on the COVID crisis across Montana. We're joined by healthcare professionals from across the state, and I'll run through everyone's name. Joyce Dombrouski, Chief Executive, Providence, Montana. Dr. Claude Tonnerre, Infectious Disease Specialist, Providence St. Patrick Hospital in Missoula. Dr. Ku, Epidemiologist, Billings Clinic. Dr. Kathryn Bertany, President, Bozeman Health, and also pediatric hospitalist, and Kallie Kujawa, Bozeman Health Incident Commander for COVID-19 response. And thank you everyone for joining in on this special Spotlight Montana. And there's so much to talk about here. Healthcare facilities in crisis mode right now, of course, with Delta cases surging. Montana is shattering records right now. So let's just go ahead and dive into this. And I'll start in Billings, and please feel free to jump into the conversation at any time. But Dr. Ku, describe what's happening right now today at Billings Clinic and what you're most concerned about moving forward.
Well, thank you, Laura. So for the past several months, starting about June, the number of newly diagnosed cases of COVID-19 have been creeping up. And it was initially slowly, but then around mid-August of this year, that it significantly jumped, and it went from about 34 cases per 100,000 to about 60,000 cases per 100,000 within in 2 weeks. We're currently at around 86 cases, newly diagnosed cases per 100,000 persons, and today we're about 86. Today we have had about over 220 new cases diagnosed, and currently holding up just over 100 patients, hospitalized COVID-19 patients in Yellowstone County. For Billings Clinic, we're running roughly about 60. I'll just get the correct number: 60 patients, and with about 23 of them are in the ICU. For the past several weeks, we've been running roughly around 50 to 60 patients total, and about a third to a half of those patients have been required ICU level care. This past week in Yellowstone County, we have had our highest number of hospitalization, running about 130 hospitalized COVID-19 patients, and with our at least in the Billings Clinic, our ICU is running about 150% of our capacity. We've also had had our highest number of deaths within a week since the start of this particular surge of 13 patients.
Wow. So in studying this Delta variant, as an epidemiologist, are we hitting a peak here, or are we even close to it? What's going to happen with this Delta variant?
But certainly with how rapidly this variant has spread throughout the U.S. and certainly in Montana, I had to take caution to predict whether we've hit that peak or not. Certainly, today I woke up seeing the headline on NPR saying that there's some models suggesting that we may have reached a peak in the U.S. But certainly, things do behave a little bit differently in Montana, as all of you probably know, and that from my experience, mathematical models tend not to be very accurate. And I recall earlier, about a year and a half, when University of Washington had published some of their mathematical models, we had we were trying to plan accordingly, and certainly found to be a little bit disappointed that the prediction wasn't as accurate, and that the peaks, or at least some of the surges we experienced, came much later than what we anticipated. So I think ultimately in the end, we'll know we have passed the peak once we passed it. So unfortunately, that's the best answer I can provide at this time.
And Dr. Tonnerre, as an infectious disease specialist, what are you seeing with the Delta variant?
So I would just second what my colleague just said. We have those mathematical model, and there's like several, like the University of Washington one, the CDC as a model. There's actually a website that kind of aggregates different models. And again, all of them kind of concur that we should be close to the peak. And it's true, if we look at what happened last year in Montana and also what happened in other states, Usually when you have that spike in cases, it takes 2.5 months to reach the peak. And we're roughly in that time frame, at least here in Missoula. Cases started to rise perhaps a bit later, like in July. So early mid-July, hey, that's roughly 2.5 months. But with Delta, we've been surprised. And unfortunately, it's been more unpleasant surprises than good surprises. So I would be as cautious as Dr. Koo saying, models are great, but we have to watch, and it's going to be likely in retrospect that we will realize, oh, that was the peak. The other problem is that we have very high numbers. So even if we reach the peak, it's not like suddenly there's going to be no new patients. We still have like similar numbers, like today, I think over 100 new cases in Missoula. So even if we reach the peak, we're not going to drop to 10 patients. We're going to go to 90 and 80. So there's still like hundreds of more people going to get infected. And the way it's going to affect all of us is that there's usually a lag between new cases and hospitalization. So even if you reach the peak in new cases, the peak hospitalization will come later, unfortunately. So no matter what, even the best case scenario, we're close to the, this week, next week, 2 weeks from now, that's going to be the max number of cases, the maximum number of cases. Well, hospitalization will continue, and it's not going to just drop off. It's going to take a while to slowly ease its way back. So no matter what, we still see a month probably of difficult times.
So no end in sight at this point. And what about other variants out there? Are you seeing them in Montana hospitals?
So go ahead.
No, go ahead.
So I know that some swabs were sent initially to the state lab. I'm not sure how much variant testing they can do now because, again, they're probably also overwhelmed. If you look at the CDC website, like 99% of the cases are caused by Delta. There is the concern about some of the newer variants. One that was mentioned is the Mu variant. And the concern is that this strain may be more resistant potentially to vaccine. Now, so far, we have not seen much. There's been like localized areas, I think in the southeast, correct me, Dr. Koo, if I'm wrong, but nothing widespread. Same thing in Europe. There were like some focal outbreaks in small areas. What's interesting is that earlier this year, when the dominant strain was called the alpha strain, you can see there was another strain that was somewhat drug resistant, and the Delta variant came. I think it was I don't remember. There was the Alpha variant was the dominant strain, the Delta was coming on, and we had, I think it was the Gamma strain that was vaccine resistant. And there was a question, who's going to win? Is it the more resistant one, or is it the one that's more contagious? Well, if you want, Delta obliterated all the other variants. So the question will still be, even if a new variant comes that's somewhat more vaccine resistant, will it really take over? Because at some point, the virus can only mutate so much, and perhaps, again, the antibodies that we have from vaccine or from natural illness may not work, but that virus probably at some point will become less contagious, because there's a cost to be so different that it may no longer be able to attach itself to the surface of a cell as efficiently as Delta. So there's perhaps a silver lining that if there's a variant, and again, we want to be very cautious with this, that may be more resistant to the antibody we have from vaccine or natural immunity, it may also be somewhat less contagious. Delta may perhaps be, some people feel like it's, as bad as it gets. But again, we've been surprised before with COVID, so we really want to be cautious with this.
Right. Dr. Tonnerre, I know you work here in Missoula. Joyce, Dr. Tonnerre, describe the situation right now here in Missoula.
Well, I can describe specifically for St. Patrick Hospital, and thanks for the opportunity. I will give you a little anecdotal story today. I was doing some town hall meetings with our staff. Our staff are really fatigued. We don't have enough staff. It's well documented. And so our goal as leaders, Dr. Tonnerre and I, is to describe the situation and be transparent and be realistic. And at the beginning of one of my town hall meetings today, I said we had 34 cases in St. Pat's. And by the time I was done with that town hall, Dr. Tonnerre corrected me. We were at 38. So the fluidity of the situation makes it very difficult and very difficult to plan for. And I think that's really one of the challenges. I've been in hospital administration all my life, and we have plans when we have more patients than we have predicted, but this is really unpredictable. And the volumes of patients that are coming in are unpredictable. And we all know the age is younger and the patients are sicker. And so we have this cadre of really, I would say, a very challenging circumstance. And I know it's not unique to Missoula, where we're getting calls from, we used to get some calls from across the country. We're finally mostly just getting calls from Western Montana and Eastern Washington and Idaho to take care of patients who are suddenly ill. And then we don't have enough staff like we usually do. Our staff have been fatigued. Some have actually made choices to move to other places to take the lucrative travel bonuses that are out there. And then the patients are sicker. And so it's really a difficult conversation to lead through. And we're really wanting to be transparent with the community to let them know that there are three things we want the community to do to help us. And we have wonderful community members who are asking all the time, how can we help? And this is my mantra: get a vaccine, get vaccinated. Wear your mask, doesn't matter where you are, and social distance. And if we can get everybody on that same page, pulling in the same direction, we feel very confident that we can work our way through this. But we need everyone to do all three things. The last thing I'd like to suggest, and was one of Dr. Tonnerre's colleagues, who indicated to me that we need to invite individuals to consider vaccination. We're done with the mandates, we're done with the mass vaccination clinics, and we need to have conversations one by one with individuals who really still have some hesitancy, hear what their issues are, and then be prepared to help them, invite them into getting a vaccine. It's so essential.
And what would you tell someone right now who's hesitant?
Well, I've been sort of known as a zealot on vaccines, and I would say just go get the vaccine. But I have learned, maybe painfully in the last 7 or 8 weeks, by having conversations with those who've chosen not to get vaccinated, to stop and understand the root cause of their fears. Some individuals really don't believe they have the data. We have a lot of data. Some people just want to be comforted or to be helped through the fact that they might have some side effects. Some individuals want to know the difference between the three vaccines. Some individuals really want to understand patient stories. What have we seen? Are patients really that sick? So it really does depend on the individual. And I go back to Dr. Lorio's comment to me. That's why we have to invite the conversation. We have to be patient, and we do have to provide the information that they feel like they're lacking.
And you mentioned staffing, and I'll go to Bozeman now with Dr. Bertany and Kallie. I saw a tweet thread yesterday, something about that Bozeman is down 400 workers. Tell me about the situation there.
So we have about 26 to 2,700 positions at Bozeman Health across our system, and we have between 400 and 500 open positions of those. We are filling many of our positions, as I've heard my colleagues discuss, with travelers or temporary workers. Some of them are emergency crisis workers who come into our organization for a period of weeks, and we don't know that we'll be able to continue to have access to those emergency personnel beyond a period of weeks, which is very concerning. We have been running at a full census. We have been at or above 95% for our 87 medical and surgical and critical care unit beds more than 50% of the time since the beginning of August. And since August, the beginning of August, we've had about 700 hospitalizations, and we've had well over 10,000 ambulatory visits for respiratory illness, and over 100 COVID positive pediatric patients that have been treated in our ambulatory setting. We have not been seeing a lot of COVID positive pediatric patients admitted at Bozeman Health, but what we have been seeing is a number of other respiratory illnesses that land kids in the hospital. And so things like respiratory syncytial virus, rhinovirus, parainfluenza virus that causes croup, things that we typically don't see in June, July, and August. We were doing admissions almost daily. And as soon as the masks came off, we saw all of these things spreading throughout our community, and our vulnerable kids were requiring hospitalization. And that increases the occupancy of the hospital, because we typically don't have a very significant pediatric inpatient population at Bozeman Health. And we've pretty consistently had quite a few throughout the summer, and that's continuing now. So we started this discussion, Laurel, with the ask about our staffing. I would say that our labor resource is probably our scarcest resource right now. We are very reliant on our travelers. We have over 90 that are working in our system. We have made a call out to the National Guard for some non-clinical assistance in areas where we need it. And we are continuously looking for, hopefully, full-time employed staff or part-time or casual call that are a part of our Bozeman Health family. But honestly, we've been having to go to every traveler agency we have access to, continuously resourcing so that we can care for our expanding demands.
And Kallie, would you like to add on to that?
You know, I think the piece about our workforce is just what Joyce mentioned. They're tired, they're challenged, they're being re-traumatized after what they experienced last winter, and with the previous surge that we saw. So I think in addition to not having enough staff, I think having seeing the staff day in and day out face those challenges and have that sort of a re-traumatized response is extremely concerning and something that we're monitoring daily.
All right.
Laura, one other piece that we've seen at Bozeman Health is that we are serving a larger population. For many of our communities in Montana, we've seen a pretty significant increase in the number of individuals who live here. And definitely through the summer, the number of visitors that we were serving. And so in May and June and early July, when our inpatient COVID numbers were 0 or 1 a day, we were still at capacity many days. And we saw between 2019 and 2020, our trauma volume went up by 50%, and we're seeing a similar increase occur between 2020 and 2021. We're just taking care of more people, and the individuals who are being hospitalized currently are just sicker. So of those COVID positive patients that we're admitting, back last year when we were dealing with a surge, maybe 10, 20% of them needed to go in the critical care unit. But today it's, as I heard a colleague say, somewhere between a third and half are in the critical care unit. And of those, up to half are requiring significant respiratory support, including ventilation.
And you're converting a nursery there to accommodate for more patients. And then we're going into flu season. What's your next plan? Will we go to bigger venues for patients?
Sure, I can speak for Bozeman Health. We have a number of contingency locations where we can care for patients in what currently are patient care areas, but are not our licensed inpatient beds. So it's a place where we would provide ambulatory procedures. We have appropriate equipment and supplies available to support patients depending upon what their medical needs are. There is going to be a point, though, that we reach the need to go beyond our traditional patient care spaces, even though now we've got our contingency plans for going above our licensed bed count to alternate spaces within our facility. We do have in our crisis plan how we care for patients when we get more than that.
And the National Guard was mentioned. Is that helping out? And Joyce, I'll start with you. I know that I think Missoula is going to get the highest number of National Guard, but more requests are coming in for National Guard members to help.
I think what Kathryn indicated is so similar for St. Pat's. We actually have space, pop-off space, if you will, but we don't have the staff. So we believe the National Guard can be helpful for us. They came last year and they did non-patient or non-clinical tasks of supplies, cleaning rooms, delivering food, and those are very essential and really do extend our clinical staff. We in Missoula County made the request to the state of Montana together with Community Medical Center and the city and county and St. Pat's in one fell swoop. We really felt it was better for us to make that request. We did it that way, and then we were granted the request pretty quickly last Friday. We've been told we'll receive up to 24 National Guard members as soon as Friday, and then we're going to work with our city and county to make a determination on where the Guard members can best serve the community. They won't probably be in either hospital in total, as we have other non-congregate staffing needs that exist in this community. But I feel really good that we've tried to bring in a precious resource and share it and prioritize where they can make the best difference.
Dr. Koo, is that helping in Billings?
Absolutely. We're very thankful for having the National Guard volunteers to help us out. And we have been primarily been placed in non-clinical areas as well as our laboratories. But our needs, we certainly still have a significant need in the clinical area, where it's getting very challenging to staff, as all of us have experienced, as well as nationwide. And we are also taking measures to expand our patient care capacity. But that's only can go so far with the limited clinical staff that we have available. So certainly any additional National Guard volunteers would be very helpful and thankful. And we're happy to get whatever we can get.
And what can the public do with the COVID burnout, the fatigue that's happening? How can community members help out?
So for us, we had the Billings Clinic Foundation and has reached out to the community, and we actually were also fortunate to have a Billings parental group for safety, as well as to promote the mask, to help support the school mask mandates, to try to reach out by supporting, just to give thanks. Because most of us, or it's not so much that most of our healthcare workers need anything in particular, but I think that many of us, just as have been pointed out here, that they've worked many consecutive days, long hours, and a lot of them are not just burned out physically, they're burned out emotionally, from just seeing the number of deaths they have to that they've never really experienced in the past. And then finally, there is this, there's also the compassion fatigue. And that's been discussed in different parts of the countries, where they're kind of losing sight of, why am I doing this? Because there are, as you kind of point out, that there are a number of people who chose to be vaccinated, and others are not, and there's these questions that go through their mind. And so I think that as it would be helpful for the community to kind of just to acknowledge and thank them. And when out in the public, just to say, hey, thank you very much for what you do, because it will kind of bring them back to what they really went into healthcare in the first place.
Would anyone else like to add on to that?
Sure. I'll jump in there with kindness and patience for our healthcare workers. So to give you an example, in our urgent care setting, on a routine basis, every day, they're managing 3 to 4 times the normal volumes of patients who are coming for treatment or testing because they're symptomatic. So imagine where you would have, 10 patients an hour come through the door. Now you have 40. And 30 of those patients are now waiting much longer than they thought they would. And the 40 that come the hour behind them are waiting even longer. And people are at times not being as kind and understanding of the hardworking teams that are putting in extra shifts and longer hours and are incredibly fatigued. And sometimes we're facing individuals who are argumentative about our infection prevention policies, our protective visitor policies, where we want to minimize exposure of both our staff and the safety of the visitor and the patients, and reduce exposure in our environments where all the sick people are coming. And we just really need the public, in addition to considering vaccination, wearing their mask, socially distancing, and please be nice to our healthcare workers. They are so tired and they want to help you. And just be patient, because sometimes when it's really crowded, it just takes a little longer.
So the crisis standards of care, so far, St. Peter's in Helena is the only hospital to declare that, and other hospitals are on the verge of doing that. Where do you stand here at St. Patrick's? We'll start with Missoula.
Right. The crisis standards of care are a conversation, honestly, that we've been having daily for about the last 10 days. We are very committed to working through what we call our contingency planning, which is really the step before we believe we would consider ourselves in crisis. And there are some very critical areas that we have not completed the contingency work. So we're working internally and helping our caregivers understand the contingency and the changes we're going to be put in place. We have crisis documentation. We have pulled back on elective surgeries. We're looking at any patient who might need an overnight bed. We're working with our medical staff to help them understand and work with us on any referrals. We get so many calls every day. And we're really being deliberate about who we can take and who we cannot take. And those are just pieces of the contingency planning. At least in our vernacular, the crisis standards of care would be a point in time where really our resources had really been so diminished that we were having to make some very difficult ethical choices. We're prepared to make those choices. We've practiced with triage teams. We've worked with our physicians. We have actually a skeleton in place of how we would move into that should we need to. We're not afraid to do that, but again, I think there's some critical steps at St. Pat's that we're still needing to take, and I think we're really hopeful that we can maintain our contingency staffing with those fundamental changes before we have to move into a crisis. I turn it to Dr. Tonnerre, though, as one of our physician leaders. He's been engaged in those conversations at a clinical level.
All right, Dr. Tonnerre.
So we've had initially the discussion last year. Again, we didn't know what would happen exactly early on in the epidemic. So we kind of prepared for the worst, because when we saw what happened early on the epidemic, perhaps in China, but especially in Europe initially, like Italy, and then what hit the East Coast, New York, New Jersey, where hospitals were just overwhelmed. So we made some of those, like I said, it's like a skeleton. There's some rule, there's some decision, there's a framework that we can use if we ever go there. Thanks God we didn't have to do it. Here, I guess we're getting close. Sometimes the analogy is like watching. You have the water rising, and when do you reach the level where the levee is going to break? And we don't know when and how it's going to be over the next few months. But we talk to people a lot. I think we have good, different working groups working on different projects. But overall, I think internally at the hospital and also communicating with outside specialists, which have been great to work with. Again, specialists who have surgery plans, perhaps 6 months, for 6 months. And then we say, sorry, you can't do this because we need the beds. We cannot make sure that your patient will have a bed overnight. They've been incredibly good to work with. And I would say the whole medical community, by the way, not just St. Patrick Hospital, but people in private practice, community medical center across town. That's been a great effort to work together and try to be as ready as can be if we ever go to the level where, again, essentially the crisis capacity, the best way to define is that there's an official definition, but essentially it's provide the best possible care given the circumstances and the resource available. The documentation may go throughout. You may not be able to care as you want. You just do the best with what you can. We're not there yet. We might end up there yet. Some places are there yet. But the key thing is to talk to people, to be ready, and be able, like we said, to be able to make some tough choices if need be.
And Kallie and Dr. Bertany, where is Bozeman with a crisis standards of care?
Kallie, would you like to take this one, or would you like me to?
Sure, I can take this one. So what we have done is evaluated the scarce resource and crisis standards of care document put out by DPHHS, and we have aligned all of our policies with that to really talk about conventional standards of care, contingency standards of care, and crisis standards of care. As Joyce mentioned, really evaluating all of those potential contingency strategies. And what we have done is we have categorized all of our services to be either mission critical, essential, or non-essential. And what that allows us to do is look at the resources that are in all of those different areas so that we can determine where we can redistribute from. So in those mission critical areas, we know that we cannot redistribute staff or supplies or anything from those areas, But from the categories of essential and non-essential, we can absolutely start taking resources, whether those are medications or supplies or personal protective equipment or staff, and start funneling those to our mission critical areas. So in addition to a lot of other things, using our volunteers in different ways and kind of putting them into more crucial roles to turn over beds in our ER and to do additional support things that they probably haven't done in the past. But we are continually evaluating all of our contingency strategies, and we have not had to move into crisis standards of care, but we are absolutely prepared to do that. And we have a full checklist of all contingency strategies that we are to consider before moving into those as an organization. And we are working our way through those.
Okay. And Dr. Koo, what about Billings Clinic?
And like everyone else, we've been exploring and planning and discussing about what to do when we reach that to that point where, well, when the state declares the crisis standard of care. But a couple of things I would like to point out is that, at least for your audience, is that it's that reaching this to the crisis standard of care isn't so much as someone who just decide to do that and with the flip of a switch. It's really part of a continuum, a spectrum of the care, ranging from conventional to contingency, then to crisis. And there's things going, and really what we have been doing on the last part of the last surge is that we've been going in and out in between these different levels. So it's not ever as if a hospital will just get locked into the crisis standard of care and that's it until something changes. The other is that we reached, as everyone has pointed out, this is a last resort. Certainly it's not something like, all right, we're here, let's just do it. But we have exhausted every possible option. But once we get to the crisis standard of care, we also work very hard trying to get out of it because that's not where we want to stay. So for your audience is that I know that there's been a lot of news circulating about what a crisis standard of care would mean to someone, the healthcare system within a community, but it's not where we're going to stay. But it's really where, just like going on divert for a hospital where, okay, we need that pause to kind of do what we need to do and then try to get out of that as quickly as possible.
All right. So then what should, let's say, I'm sick tonight, or someone showed, it may not be COVID, it may be something like that, but you have to go to the hospital. What's going to happen when they arrive?
So if someone is ill, they should absolutely present to the appropriate level of care. If it's the emergency department, your primary care provider, an urgent care, or if you need to call 911. And all of our health systems will meet your medical needs. Now, if we are in contingency or crisis mode, that may just look a little different, but we do not want you to in any way defer going to the hospital when you're sick and you believe you need medical care.
Okay. Yeah, so because you're hearing people are worried that they'll be turned away, that they have a heart condition, but they're turned away and they go home.
So when Kallie spoke about our mission critical services, anything that's time sensitive, the treatment of a heart attack, the management of a stroke, a trauma victim coming in, someone who is septic, those are time sensitive emergencies, and we absolutely always manage them. Any patient presenting to our emergency department is always accepted, evaluated, and stabilized. Now, might we need to transfer a patient or care for them in a different location in our hospital than we normally would, based on if we are in a contingency mode, possibly, but we will always care for them.
Does anybody else want to add to that?
Yeah, I want to second that. This has been the challenge, to try to still provide those crucial life-saving services to the community. And how do you strike the balance between, being available for those services versus, again, having this extra I would say, work caused by the COVID surge. But I think I agree with what I think it's the same in Bozeman, Billings, and I'm sure throughout Montana. People really try their hardest to still provide those life-saving essential services. And again, I agree. If somebody's sick, really sick, if they need to go to the hospital, go to the hospital. It may take perhaps a bit longer to be triaged. You may stay perhaps in the emergency room longer because there's not yet a bed upstairs, but the care is still there.
Right. Well, as we start to wrap up here, I just want to go around the room, so to speak, and your final message to our listeners out there, and we can start with Dr. Ku.
I'm going to echo what Joyce said, and as well as Kathryn, and that it just is that our probably the most important thing for us to do is try to encourage all those. There's three key things that we talked about: trying to get as many people vaccinated as possible, trying to get everyone to to use a mask when they're out in the public as much as possible, and to maintain physical distance when feasible as much as possible. The thing is that the chatter I hear on Twitter as well as out in public is that a lot of this has boiled down to a personal choice. But the issue is that this is actually a community effort. This is not a zero-sum game. This is a non-zero-sum game, actually, and that everyone will benefit from this. So if I wear a mask, it's not me. Or if I get vaccinated, it's not just me who will benefit from it, but everyone around me and beyond that. So I think that's the key thing is it's a public, it's a group, it's a community effort. And I see Montana as a community that if we can all do, as many people can do this, then we all could benefit from that. And then finally, as I pointed out earlier, is that our healthcare workers get a lot. They've gone through a lot, and if you get a chance to see them, just say hi, acknowledge them, thank them, and they and they'll just that little bit of gesture will just help. Of kindness and gratitude will really help will go a long way and help redirect their purpose. And the goal is, as we have all kind of pointed out, is we want to be there to help them. That's why we chose this occupation. We just need to kind of remember that sometimes.
Dr. Tonnerre.
I just make a quick personal statement. I'm old enough to have started my medical career before there were good treatments for HIV infection. And I still remember doing my first clinical rotations where you had those wards with HIV patients with different, opportunistic infections, because the immune system was so low they would catch everything and then some. And you would look at those patients in the eye and say, we'll try our best, but you knew these people would die within months. And there was this horrible sense of dread. And of course, now for the last 25 years, we have good treatment for HIV. We cannot cure, but we rarely see patients like this anymore. To some extent, that sense of dread, that sense of, oh my God, I haven't had this ever since. And except now it's compressed. It's in a matter of many more patients in a short amount of time and dying. And this is incredibly difficult to deal with. And I have to say, I give a lot of credit to as physicians, we spend time with the patient, but really the nurses, the people who spend a lot of time with them, it's incredibly hard for them. So what was been said before, be kind with those people. They really need, the help and the support. But again, it's kind of that kind of, hard, difficult situation where in the ICU and you look at somebody and and this is not going to be a matter of months, it may be a matter of days before they're gone. And it just breaks your heart. I mean, you see their pictures of their families on the wall, you see, drawings from their kids. And that's always at the end of the day, somebody's father, sons, an individual who dies. It just breaks your heart and it's difficult. And again, I can only encourage people to get the vaccine. And the other thing, talking about the vaccine, don't forget the flu vaccine. We essentially had 0 cases of the flu last year. Well, people were social distancing, wearing their mask. We know this is not going to be the case. So I would beg people to also do the flu vaccine. I know that typically influenza comes late during the flu season. It's more like February, March, April. But we don't know what's going to happen this year because, again, it's a big unknown. We didn't have flu last year, so it could happen anytime. So please go get the flu vaccine as well.
And I got mine on Friday. Kallie in Bozeman.
Sure. Yeah. I just want to remind everyone that our number one priority is keeping all of our staff and all of our patients and our community safe and healthy. So we really encourage everyone who needs care to seek care when they need it. We are here to care for all patients, not just COVID patients. We have telehealth options available for people who don't want to be seen in person. And while, again, we are seeing such high numbers of patients, we don't want anyone to delay care. We hope that everyone will understand that the current situations of our hospitals in Montana is not good after tonight's conversation, and that we need every single person who can get vaccinated to do so. We want to encourage everyone to wear a mask, to do the simple things like wash their hands, and to stay home when they don't feel well. And I just really appreciate you having this venue for us to share this information.
Right. Dr. Bertany.
Well, I know I sound like a broken record from my peers, but for those who can get a vaccination, please get a vaccine. You're protecting not just yourself, but your loved ones and those in the community who are very vulnerable and not able to get vaccines. So currently our youngest children can't be vaccinated, and some individuals with immunologic deficiencies can't be vaccinated. And so creating that herd immunity in our community will help others, in addition to helping yourself and your family. Wear a mask. Wear a mask anytime you're not by yourself, I'm going to say. And when it comes to social distancing, really think twice before you go out in a crowd of individuals that aren't part of your pod that you live with or work with every day. And even when you're with those that you're with every day, wear a mask. And as you've heard before, please be kind to each other and say a special thanks to your healthcare workers.
Absolutely. And one question I forgot to ask earlier, do you feel when it comes to protective measures and wearing masks and vaccines, do you feel the president, the federal government, the state needs to do more?
Well, this is Joyce. I was thinking about wrapping up rather than answering that question. I think at least the professionals in Montana have been very clear about the challenges we're facing and maybe some of the legislative challenges that we feel have hampered our efforts. So it's always difficult to say do more. I think we're being listened to. I think our plan is to continue to look at the science, look at the data, be really transparent about what we're doing, and then be part of the solution. So when any legislator or any official from the governor's office asks what can be done, I think they're getting a very clear message about what we think needs to happen. And really the science is so critical, and I think we just need to go back to that over and over again relative to vaccine efficacy, relative to the challenges we're facing. And so I would just say that's my message as the wrap up. All the things that my colleagues have said, we need to work together. We're in this together. Our focus is on saving lives and helping our caregivers stay focused on doing that. And we're pleading or begging with the community to understand how they can help and to take that action on their behalf, but really on behalf of the community.
Absolutely. All right. Well, thank you, everyone. This wraps up this Spotlight Montana. And those listening, if you want to watch this again, you can just find this on our website, NBCMontana.com. Thank you.
Thank you.
Thank you.
Thank you very much.